welcome back to my channel. Today I am going to discuss about a very important and very interesting topic, that is hyponatremia. In our day-to-day life practice, we can see various patients having hyponatremia. So how to manage it? You will get lots of cases of hyponatremia every day. So let me discuss it in a very simple way. First of all, the patient who are very predisposed to hyponatremia are the post-traumatic patient, post-operative patient, and elderly patient and children. So whenever you will get some kind of RTA cases like post-traumatic road traffic accident cases, they may get hyponatremia. If they are having generalized tonic-clonic seizures every minute, you may suspect that the patient is having low sodium levels. And also, if the patient is elderly patient, there can be also hyponatremia. So, and in case of children also there can be hyponatremia. In case of post-operative patient, there can be hyponatremia, because in case of post-operative patient, ADH hormone is secreted very much. So guys, how to manage this and how to manage hyponatremia very accurately, because if you don't manage hyponatremia accurately, you may kill the patient. So guys, first of all, always see the symptoms of the patient, the signs of the patient. If the patient is dehydrated, whether the patient is confused, disoriented, if the patient is not responding, if the GCS is low but the CT scan is normal, then you must suspect hyponatremia. But before doing CT scan, because CT scan is not available in every facilities, so first of all, if a patient is confused and disoriented, the first and foremost thing you have to keep in your mind is hyponatremia. Give the sodium potassium test. You may find the sodium is less than 135, and now you have to decide whether the sodium is less than 120 or more than 120, but less than 135. So if the sodium is less than 135 but more than 120, that means the prognosis is good. You don't have to worry now. Now you are at the patient is at a good hand. I mean, you can save the patient very early with just simple 12 Vaptans. And if the patient is having hypovolemic, if the patient is having signs of dehydration, look for the signs of the dehydration. Give IV fluid, normal saline. But here, one of the important thing I'm gonna say you that give the normal saline only if the patient is coming after 48 hours of onset of hyponatremia. Now, how to know that the patient have arrived after 48 hours of onset of hyponatremia is that you ask the family members that from how long the patient is not responding, from how long the patient is not talking at all. The patient is talking from how long the patient is having altered sensorium. If the patient is having altered sensorium from the last 48 hours and the sodium level is less than 120, more than 120, then you can give normal saline if the patient is dehydrated. But if the patient has come within the 48 hours, the onset of hyponatremia is within 48 hours, then it is acute hyponatremia, and in that case normal saline is contraindicated. Always remember that, because if you give normal saline in a patient who is having hyponatremia and its onset is just 48 hours before, you may kill the patient. You are doing more harm to the patient than that of doing good, because normal saline is easily prescribed. When a patient comes with altered sensorium, when a patient comes with dehydration, we easily go for normal saline. Like, we prescribe normal saline, give normal saline, the patient will, if the BP is low, we give normal saline very easily. But not in all cases you will have to give normal saline, because in acute hyponatremia, never give normal saline. It will decrease sodium more and more, and the patient will have acute cerebral edema, and the patient will have herniation of the cerebrum, herniation of the brain, and there will be coning and there will be death. So it is a very important point. I hope you will remember this, that you will have to give normal saline only if the patient have arrived to you after 48 hours of onset of hyponatremia and the patient is having sodium more than 120 milliequivalent per liter, more than 120 millimole per liter, and there are signs and symptoms of hyponatremia. So guys, first of all, you have to see whether the patient have arrived to you within 48 hours or more than 48 hours. If the onset of hyponatremia is within 48 hours, that means this is acute hyponatremia. In that case, you have to give 3% NaCl within 10 minutes and with not round the clock, but within 10 minutes, within 10 minutes 100 ml 3% NaCl must be given, and within half an hour 3% NaCl 300 ml must be given. That is the first and foremost correction of hyponatremia. In case of acute hyponatremia, that is within 48 hours. But after 48 hours, that is chronic hyponatremia. In that case, there are two options. If the sodium is less than 120 milliequivalent per liter, then we will have to give 3% NaCl once daily and throughout the round the clock within 24 hours, not within 10 minutes. But if the sodium is less than 120 milliequivalent, more than 120 milliequivalent per liter, more than 120 millimole per liter, then we will give 12 haptans and diuretics. And if the patient is euvolemic, we will give 12 haptans, and if we will not give normal saline. But if the patient is hypovolemic, we will give normal saline if the sodium is more than 120 millimole per liter. But if the sodium is less than 120 millimole per liter and the patient is euvolemic, we will not give normal saline. So hope this video is helpful to you. Always give 3% NaCl very cautiously and very slowly at the rate of 6 drops per minute. If you give very fast, more than 6 drops per minute, the patient will have demyelination, osmotic demyelination syndrome, which is a very severe condition, and pontine demyelination syndrome. So to prevent that, we have to give 3% NaCl very slowly at the rate of 6 drops per minute. Hope this video is helpful, and if there is some confusion, you can ask in the comment box. Thank you.